I'm Professor Ramanan. I'm a pediatric rheumatologist working at the Bristol Royal Hospital for Children. I'm also based at the Royal National Hospital for Rheumatic Diseases in Bath. Our pediatric rheumatology practice covers the whole of southwest of England, and we also do some outreach clinics in some parts of South Wales. So I would say that's a catchment population of about 5 million. Our unit has 4 consultants, 3 full-time equivalent. We have 2 specialist nurses. We have a physiotherapist, an occupational therapist, a clinical psychologist. We're also a recognized center for training in pediatric rheumatology, and we usually have 2 trainees, one of whom is a dedicated trainee in pediatric rheumatology, and other is a pediatrician who wants to get experience in rheumatology. So in Bristol, one of our areas of interest and expertise is in management of children with uveitis secondary to JIA. So in 2005, myself and Professor Andrew Dick thought it would be a good thing for both of us to sit in the clinic together and see these patients with complex uveitis. And the reason for this was we found patients were being seen by the ophthalmologist, and then the communication was being cascaded quite late for us to initiate the appropriate immunosuppressive therapy, and valuable time was being lost. And the second reason was that the communication in the letter was not as effective as it would be if we were sat in the same room, so that we could optimize the treatment, which would target both the joint disease in these children and the eye disease in these children. So we commenced joint clinics in 2005, and the evolution of these clinics has been quite interesting, because we initially thought that there won't be many children, but what we have found over the years is from running the clinics every 6 months, we are now running them every 2 weeks to every 4 weeks because of the exponential increase in the need for these clinics. And currently we have a model where all children with JIA are screened by a very experienced nurse specialist based in the eye hospital. As soon as anyone has evidence of uveitis, they go under the care of Dr. Gooley, who's a specialist in uveitis. And all children who need any form of biological treatment or any escalation of treatment are seen in the combined clinic that myself and Andrew Dick run together. Whenever a parent, child, or anybody hears that their child or one of their relatives has got arthritis, they're quite surprised, because the conception is that arthritis is something which happens in older people. Unfortunately, 1 in 1,000 children in this country get arthritis, and the type of arthritis that they get is what we call as juvenile idiopathic arthritis. Juvenile meaning getting it in the childhood, idiopathic suggesting we still don't know exactly why they get it. And there are several types of arthritis, but very simply put, the most important bit is you can get it in a few joints when it's called oligoarthritis. You can get it in multiple joints when it's called polyarthritis. And sometimes you can get it in a type which can affect the spine later on, and we call that enthesitis-related arthritis. There are subtypes within the oligo and polyarthritis, but when you get it in a few joints, sometimes it can extend to involve multiple joints, and we call that extending oligo. And when you get polyarthritis, it can be of 2 types again. Those who have rheumatoid factor positive, and these tend to be the older teenagers, and it's essentially adult rheumatoid arthritis happening slightly earlier. And then you have those who are rheumatoid factor negative, which is a more common subtype, and that can affect at any age from about 2 years to 16 years of age. There is also another type of arthritis which is very different and distinct in its presentation, which is called systemic onset juvenile idiopathic arthritis. And these are children who, compared to the other types of JIA, usually will be unwell, because that's why it's called systemic onset. They'll have fever, they can have rash, they'll feel very fatigued, and their presentation will usually mean a stint in the hospital, and they'll be diagnosed through that route of having been an inpatient or being unwell for weeks and sometimes months. Juvenile idiopathic arthritis is an uncommon but not as rare a condition as people think it is. On average, we'd say about 1 in 1,000 children in this country will have a chance of getting arthritis. And about 1 in 10,000 is what we'd say as the incidence, the prevalence being 1 in 1,000. Some types of arthritis are much rarer. Systemic onset JIA is much rarer, and we'd say that's about 1 in 100,000. But when you add all types of arthritis together, I think the best figure for us to bear in mind for any parent carer is about 1 in 1,000 children in this country will have a risk of getting arthritis or will have arthritis. So the most important variable in management of children with arthritis is early and appropriate diagnosis. And the diagnosis can be delayed for a multitude of reasons. Both in undergraduate and postgraduate curriculum, historically, musculoskeletal examination of children has not been well taught. So we have a whole cohort of primary care practitioners and secondary care pediatricians who have not been exposed to examining joints. So when children present to them with joint pains, the knowledge base that is there, the examination techniques may not be there to enable them to consider this diagnosis and refer appropriately. And delay in referral, which has been shown both in UK and elsewhere, is one of the biggest factors in affecting the long-term outcomes. If we do not diagnose early, then we risk causing some joint damage. We also risk in not being able to initiate the appropriate therapies early, which can have an impact in changing the course of the disease. There are several moves afoot, and I think the work of NRAS is very important in highlighting to the general public as well as the parents that children can get arthritis too. We are working with general practitioners and the Royal College of Pediatrics to try and highlight the importance of joint examination for those working in primary care and those who are going to be general pediatricians, so that we can enable the fact that both parents, the public, the primary care physicians and pediatricians are aware that children can get arthritis, and that the physicians are equipped with the skill set to be able to examine these children and refer them appropriately to tertiary pediatric rheumatology centers for further management. One of the areas which has been revolutionary in the management of children with JIA has been the advent of new agents. So in the 70s and 80s, the diagnosis of JIA meant that within a few years these children will be wheelchair bound. The only drugs which were available then was steroids and later on methotrexate, which, whilst effective, was not completely effective in significant numbers of children. The last 10-15 years has seen the advent of a new class of drugs called biologics, and these have resulted in fantastic outcomes. So if we can diagnose the children at an appropriate stage early, and we can treat them with methotrexate and if required with these biologics, the outcomes are pretty dramatic. So much so that when you see children with arthritis play with their siblings, and we are asked to point out which child has got arthritis and who hasn't, it would be virtually indistinguishable. And the goals of treatment these days, when we see a new child with arthritis, is to tell them that they can aspire to do whatever they want. If that is to play a contact sport, mountain climbing, they can do so. And our job as professionals is to help facilitate that happening. So there are virtually no restrictions or any lack of desire in whatever they want to achieve. We can help facilitate it. So that bit of management of juvenile arthritis has undergone an almost revolutionary change. And this is carrying on with the advent of more and more newer drugs. So even the small number of patients who are not controlled on one biologic, we can now try and control them on another biologic. So what are the long-term outcomes and outlook for children with arthritis? In a percentage, probably a significant percentage of children with oligoarthritis, those who have very small number of joints affected, probably there is a greater chance of remission. But in a significant number of children with polyarthritis, there is a 70 to 80% chance that they're going to carry this disease into adulthood. And when they do this, the importance of transitioning them from the pediatric rheumatology setup into the adult rheumatology setup becomes very important. And this process not only entails the several changes that the individual's undergoing as they move from being a teenager to an adolescent to a young adult, but it also is about the provision of services. And one of the important variables here is not to label the children with juvenile idiopathic arthritis as soon as they turn 18 as a rheumatoid arthritis. These are two distinct conditions, and the best example of this is if a child with JIA is treated very well, then erosions on the X-ray is almost never seen or very rarely seen. as opposed to the very early onset of erosions in adult rheumatoid arthritis. So one of the things we want to talk to our adult rheumatologist and avoid doing is relabeling of children with juvenile idiopathic arthritis when they move into their adult clinics as rheumatoid arthritis. The second is the provision of services which are tailored for children, adolescents and young adults, so that they're not seen in the context of a clinic which has got osteoarthritis and rheumatoid arthritis in a different age group to those that these children are being transitioned to. And adult rheumatologists need to understand that the outlook and outcomes of children with juvenile arthritis is significantly better these days if they are appropriately managed. So the treatment of children with JIA depends very much on the subtype they present with. So if we take a child who presents with a few swollen joints, 1, 2 or 3 swollen joints, what we'd call as the oligoarticular JIA, the first line of treatment in most centers would be to give them non-steroidal anti-inflammatory drugs. But these are not going to be taking the arthritis completely into remission, but these are to relieve the symptoms associated with the arthritis. But the mainstay of treatment would be intra-articular injection of steroids. And we try and use long-acting steroids. And in younger children in most centers, this is done under a general anesthetic to minimize the discomfort that they have. And it's only in the older children we will try and do this with local anesthetic in the form of gas and air or Entonox or nitrous oxide. So in a majority of the children with oligoarthritis in a few joints, the joint injections might be enough to keep the arthritis under control. Occasionally you may have to repeat the joint injections. But if you're having to do the joint injections at very frequent intervals, or the joint injections are not sufficient in controlling the arthritis, then in the children with oligoarthritis you will consider adding in a disease-modifying drug. And the first line, and the one with which we have the most experience in children, is methotrexate. It's very well tolerated, although there are nuisance value side effects in the form of nausea, which about 20 to 30% of the children will experience. It is unusual for children with oligoarthritis or arthritis involving a few joints to need therapies beyond methotrexate. But there may be a small group which will be very refractory, even though it affects only a few joints, which is not controlled with injections of steroids into the joints, not controlled with methotrexate, in whom you might consider further escalation of therapy in the form of biologics. The management or the treatment of children with polyarthritis, those involving multiple joints, is very different. Because of the number of joints involved is a reflection of the severity of the disease. It's almost always likely that they will start on methotrexate immediately. And in some of them, it might even be through the subcutaneous route as a tiny injection into the skin. Alongside this, depending on the type of joint involved and the number of joints involved, possibly a short course of oral steroids, or in some cases a short course of IV steroids, is usually done, depending on the patient's preference as well as the pattern of joint involvement. If after 3 to 6 months of methotrexate there is not complete control of the arthritis and they have flare in a couple of joints, you might choose to do joint injections of those joints. If there is continued activity in multiple joints, then you will escalate to a biological therapy. And usually we should be able to do it within 3 to 6 months assessment. So for management of polyarthritis, you would commence methotrexate at diagnosis, coupled with very good physiotherapy. And at 3 months, you will assess. If the arthritis is active only in 1 or 2 joints, you will resort to joint injections of those joints. If it's active in multiple joints, then you would have to move on to the next line, which would be a biologic. So one of the most important aspects in management of arthritis is empowering patients and the children to get more information about the arthritis so that they can effectively work with the medical professionals. And I think one of the important resources that they can all access is JIA at NRAS. And NRAS has provided a very good platform of collecting not only resources from other sites, but also providing resources on their own website so that both patients and their parents can get a good understanding of what the disease entails, and probably through this establish networks to contact other families as well as other children who are in the same situation as them. So I'd be very supportive of them looking at the JIA and RAS website, and through that getting access to the information they need.